Great.
Okay.
Good afternoon, everybody, and welcome to the webinar. Today, we are in our COVID and CVD series, talking all about COVID and how it relates to the heart. This webinar, we're focusing on COVID-19 and really how it impacts the heart. So we're really excited. This is webinar 3 of the series. If you haven't been able to watch the first 2, they are on our website that you can go back and watch the recording. Today, before we get started, I just want to update you all on Mended Hearts. If you're not familiar with us, we our mission is to inspire hope and improve the quality of life for heart patients and their families through ongoing peer-to-peer support, education, and advocacy. And you can find us all over the web at mendedhearts.org, mendedlittlehearts.org, and on social media as well. Before we begin, and I turn it over to our fabulous speaker, I just want to make sure everybody knows attendees are in listen-only mode. If you can't hear, hopefully you can see the screen and you can know that the audio button on your personal computer is typically the issue. So just check and make sure that your sound is on. Please type your questions into the Q&A box at any time during the presentation, and questions will be read and answered after the presentation. Just as a note, the presenter will not be able to answer specific questions about you or your child because you are not their patient and they're not your treating physician. So please try not to make them really specific to your case. And then finally, a PDF version of the slides, as well as a recording of this presentation, will be available on the Mended Hearts website following the event. And so now I would like to introduce to you our speaker for today, Dr. Nelipovich, who is an attending cardiologist and a director of the Women's Heart Program at Medical Center. There's always one of those that messes me up. She completed her cardiology fellowship at New York Presbyterian Hospital and New York Hospital Center, Queens. And she has been a teaching cardiology attending physician since 2011. And so with that, I would like to welcome you and thank you so much again for joining us for this hour. And I'm going to turn it over to you. Would you like me to allow you to control the slides, or would you like me to just forward them for you?
If you can forward them for me, I'm speaking from my cell phone.
Okay,
that's the best connection I get.
That's absolutely. Okay. All right.
Thank you for having me. Thank you for having me on your webinar, and I really appreciate the opportunity. Most of the educational activities we do used to be face-to-face, and I think Zoom actually expanded the opportunity to reach more people. So I really appreciate this time. So I usually do my presentations about how do you prevent heart disease. Unfortunately, this pandemic really threw in a curveball for us. So I'll talk a little bit about COVID-19 disease, how it affects the heart, and what can you do to sort of keep yourself safe and prevent things. First of all, if we talk about COVID-19, what is COVID-19? COVID-19 is actually the name of the disease that the virus known as the SARS-CoV-2, severe acute respiratory syndrome, coronavirus 2 causes. The virus itself is very tricky, and it has been evading a lot of immune systems, but I think we're finally getting to the point where we have tools to control it, unlike in the beginning of 2020. The way it infects the body, like many other viruses, it can cause a range of different symptoms, and some people may be asymptomatic, some people have fever, dry cough, muscle aches, loss of taste and smell, but some people develop much worse reactions, including pneumonia resulting from the virus, sepsis, acute respiratory failure, organ failure, and even death. The problem with the virus is it affects the cardiovascular system. It affects the pulmonary system, your lungs. It also affects people who already have pre-existing conditions, such as coronary artery disease, such as diabetes, such as hypertension. In fact, people who have risk factors for coronary artery disease, people who have risk factors for these cardiovascular conditions, they're much worse at risk of complications and increased risk of death. And a pandemic itself, because of the way it overwhelmed our medical system, and even here in the United States, it has caused significant problems in delivering care and caring for our patients with heart disease, recognizing heart disease early and treating heart disease as well as coronavirus itself. We can advance the slide. So as of November, this is from this weekend. So CDC published, this is recent data from this weekend. In the last, since the beginning of 2020, in the United States, up until this Sunday, there were 46 million cases of coronavirus disease recorded. It has cost 751,000, and over that now, that's in the United States alone. There are some good news and some bad news. The good news is because of the emergence of different vaccines we have available, we have reached a high number of people who are vaccinated. Per CDC, people receiving at least one vaccination for coronavirus has gone up to about 78%. But the community transmission is high and people still have to take measures to protect themselves. So why is this so important? If you can advance the slide. This is like very complicated. I don't want it to be very, 8th grade biology. My son would really love this slide. But the point of this virus, it affects all cells. The way it interacts with the cells in the human organism, it found a protein that's vulnerable. This protein is a little molecule that sits on the surface of the cell membrane. And when the virus finds it, there is a way the spike protein, the infamous spike protein, it interacts with this protein called ACE2. ACE2 stands for the angiotensin 2, and it's a little protein that usually plays a pretty important role in the angiotensin system in the body. The system that regulates a lot of the cardiovascular things, including blood pressure and some electrolytes in the body. Usually ACE2 sits on the surface and does its own thing. But when the virus interacts with it, it basically hijacks the cells. It hijacks the cells and uses ACE2 to get into the cell, and then proceeds to replicate itself, make more viral particles, and then emerge and reproduce. The problem with this is it disrupts and you can advance the slide, and this is sort of what we talk about, it disrupts the function of the actual cell. It disrupts the function of what this protein meant to do. Problem with this ACE2, remember, it's a part of renin-angiotensin system, the system that regulates blood pressure and other cardiovascular things. The problem with it is ACE2 is expressed a lot more in the very vital organs, like the lungs, like the heart, like the blood vessels, like the kidneys, liver, and gastrointestinal tract. This is why when the virus infects the body, it produces such a big range of different issues. The problem is ACE2 is meant to be sort of a feedback portion of this angiotensin system. It's meant to actually decrease inflammation, cause dilatation of the blood vessels. It's an antifibrosis and antioxidant response. Now, if the ACE2 is not working because it's hijacked by the virus and the virus now is reproduced in the cells, guess what? These mechanisms will be altered. So part of the reason that coronavirus affects the body so much is it basically alters our normal responses. So there is more constriction in the blood vessels. There is more dysfunction in the cells that regulate the lining of the blood vessels. There is more salt retention and electrolyte abnormalities as a result of what the virus does to the body. We can advance the slide. So this is probably the key to sort of what does the virus do to the body. And it's not one thing or the other, it's many different things. On the level that you look at, if you look up on top of the diagram, so the virus directly damages the cells, including cardiac cells. There have been studies that demonstrate that the virus gets into these cells. And because the cells now become factories to manufacture more virus. They don't do what they're supposed to do. In addition to that, because now the cells are altered, there's inflammation of the cells. So virus itself causes direct injury to the cardiac cells. And this is part of why myocarditis is such a big deal with COVID-19. Another way the virus interacts is causing systemic inflammation. Now, in cardiology, we hate inflammation. Inflammation is not good. Diabetes leads to high inflammatory state. Obesity leads to high inflammatory state. And the problem is the virus itself, because it's an infection, causes inflammatory state. And these little molecules called cytokines. Cytokines are little molecules present when immune system gets activated as a response to the virus. Well, these are the ones that do even more damage than the virus itself. You probably heard this expression of cytokine storm. Well, cytokine storm, you have tons and tons of these tiny little particles now in the body causing more inflammation. Inflammation is not good for the body. You know, inflammation was never good for the body, and inflammation is much worse to the body because of the coronavirus. So now you have inflammation in the cells lining the blood vessels. You have inflammation that's causing damage directly to the cardiac cells. You have inflammation that increases the clotting risk. You know, don't forget there's also increased risk of stroke and clot formation called deep vein thrombosis, DVTs, because of the virus, because of this inflammatory immune reaction. There's another way the virus affects the body. And the way it affects the body is it alters how the demands on the body. Any infection is a stress test for the body. Now, the heart has to pump faster, the lungs have to get more oxygen, but they can't. So you have this, what's called mismatch, meaning there's a high demand and there's not enough supply. Kind of like was in the stores with the toilet paper. There was not enough, there was definitely not enough supply and tons of demand. But this is worse for the body. It's not like toilet paper, it's oxygen. Oxygen is vital to so many organs. So now you have increased demands to get more oxygen to all these tissues. And the heart just can't deliver. The heart can't deliver because it's not getting more oxygen from the lungs, because the lungs are affected by the virus. Remember, the virus doesn't just bind to the cardiac cells, it's binding to the cells in the lungs. It's causing those pneumonitis, pneumonias, and direct lung injury. So now you don't have a good oxygen exchange to begin with. And then the heart has to pump much faster because the blood pressure is low. And the heart cannot pump very well because the cells of the heart are infiltrated with this infection. So you have a perfect storm, which leads to more multi-organ failure. Another way is the microvascular dysfunction, the clotting predisposition. Now, when the heart has to pump faster, there is something that happens, circulation, the blood cells have to move much faster through the blood vessels. It causes something called shear stress. So there is a stress on the actual blood vessels themselves. Now, if you have vulnerable plaque and there's a predisposition of a person to have coronary disease, this pushes the body over. This pushes those plaques over. The plaque can rupture and a person can have a heart attack as a result of increased demand on the circulation, on the heart, on the body. So if you look at it this way, there's more than one way a person can have injury to their cardiac cells, the myocytes. And this is the part that causes the acute heart attack. Now, what we have been seeing with coronavirus itself, with the COVID-19 disease, is also heart attacks that are not just caused by plaque rupture, but predisposition to clotting. Even when we bring these patients to the lab to open up the blood vessel during a heart attack, a lot of the times there's such a big burden of the clot that no matter how we try to get the clot out and we suction it out with special catheters and try to put in a stent, a person keeps on clotting. And this is the scary part, because of the clotting predisposition. And clotting predisposition is there because of the dysfunction of the endothelium. Endothelium is the lining of the blood vessels, and because of the predisposition to the thrombus formation. And there's also another thing. Remember, kidneys are affected too. So now you have electrolyte imbalance in the body. And one of the most sort of important electrolytes in the body, potassium, is affected. There's very low potassium levels when the coronavirus infection is severe. And these low potassium levels, as a result of the infection, they lead to arrhythmias. in addition to everything else. So there's more than one way the heart is damaged. And sort of if we could advance the slide, I summarized some of it of what I talked about in the previous slide. I think we don't have to read through it. I think the picture sort of demonstrates all these things. So there's more than one injury. There's multiple ways, and very often it's one on top of the other. And all of these different things cause injury to the heart, injury to the body, and to the point where the body can no longer fight the infection. It's trying to just get by, and this is why mortality for this disease is so high, because there's more than one way it affects the body. We can go to the next slide. So how does it impact the heart? What do we see with coronavirus? So we do see some heart attacks as a result of coronavirus infections. We see arrhythmias. Arrhythmias are irregular heartbeats, but there are different types of arrhythmias that we see with the coronavirus. Some of the arrhythmias are deadly. This is called ventricular tachycardia, ventricular fibrillation. They're fairly rare, but we do see those arrhythmias in very, very sick people. A lot of the times people report other arrhythmias, fast heartbeats. People feel what they call palpitations when they're aware of their heartbeat. A lot of them are sinus tachycardias. Some of them are tachycardias in the upper chambers of the heart, something called supraventricular tachycardias. These things make coronavirus, disease so much more uncomfortable, because now people feel their heartbeat. Forget about, somebody who's having a heart attack and is going into a bad arrhythmia that requires a shock. Obviously, that's a deadly situation. And then you couple with that with the chest pain because of either the person having a heart attack or person having myocarditis, the inflammation of the heart muscle, because that hurts too, and that hurts a lot. Overall, the extra stress of the body being so ill, it can lead by many different pathways we just talked about to heart failure. So if we talk about the arrhythmias, it's still an area of research. Publications that we have are not huge studies. It's case reports from different countries, which people manage to publish. And sometimes it's as little as 100 people in each study. Sometimes it's a couple of hundred people that, per specific doctor was looking at. And the case reports, so I don't have very good statistics of what's the percent of people who have bad arrhythmias. Some of the things that were published state that, the actual bad arrhythmias, and we're talking about people who are hospitalized. We don't know what it's like outside. If you're not in the hospital, we don't have all of the information of what's going on with the people. So it's the people who are so sick that they require to be in the hospital. So these people have up to 5.9% in one study that quotes bad arrhythmias, the type of arrhythmias that kill. This is when the heart stops beating and you have ventricular tachycardia, ventricular fibrillation, and this requires resuscitation effort, meaning delivering shock, delivering chest compression, CPR. But a lot of other things that present, it's not the only way the person dies of coronavirus itself. A lot of times there's pulseless electrical activity. So it looks like the signal is there, but the heart's not beating because of other organs that are failing. A lot of the times it's, other conditions that lead to that, not just the arrhythmia. Arrhythmia actually seems to be a small percent of it. However, in people who are so sick, any little thing can push a person into a worse condition. Also, in the beginning of pandemic, what we noticed, some of the medications we were trying to use, I remember we don't have FDA approval for a lot of medications that work well. This is a brand new virus that we're studying as we're trying to treat people. So we go by the best evidence available. So in the beginning, hydroxychloroquine, which is no longer FDA approved to use, we tried in very sick patients in the hospital. And what we noticed, there was something called QT prolongation. QT prolongation is a finding an electrocardiogram that corresponds to a particular time in the cardiac cycle when the cells are supposed to return to their normal state, repolarize. Now, prolonging this particular time leads to predisposition to certain deadly arrhythmias. So this is why hydroxychloroquine was always used very cautiously, and we had to do EKGs on these patients and watch closely. However, in the studies that have been done since then, hydroxychloroquine did not prove to be effective in treatment of the disease. It did not reduce mortality. So FDA withdrew its approval for it to be used in COVID-19 illness. Azithromycin is an antibiotic we very often use, sometimes even outpatient, for treatment of secondary infection, like secondary pneumonia. And it is, especially in combination with hydroxychloroquine, also prolonging the same QT. So this could bring the arrhythmia along or increase risk of it. So arrhythmias is one of the concerns that we have. There is something also that's emerging and described in literature. I didn't put it in this here. It's a kind of like orthostatic tachycardia syndrome, like posture orthostatic tachycardia syndrome that we see in COVID illness and also in post-COVID recovery period, where people do not tolerate exercise well, do not tolerate getting up rapidly, and they report fast heartbeats, palpitations. A lot of the times this resolves with time, but it has been described as a part of the arrhythmias in the COVID-19 illness. Now let's talk a little bit about acute coronary syndrome. There's two parts of it, because the way we think of a heart attack, there's some heart attacks, most of them, the classic ones, that are caused by plaque rupture, and the plaque rupture leads to a red clot formation, which blocks the blood flow to the coronary blood vessel. The problem is it's only a small percent of the people who are ill with coronavirus that actually end up having that. A lot of it, so this is called like a type 1 MI, because of the plaque rupture and the closed blood vessel. Type 2 MI is something that we see a lot more often with coronavirus illness, and it's produced by EKG changes. And when you see EKG changes, you see biomarkers known as troponin. It's one of the biomarkers for cardiac damage, but it's produced because of the increased demand on the heart, and the heart cannot catch up to that demand. And it actually does not correspond necessarily to a blocked coronary vessel. However, if you look at the realm of acute coronary syndrome, some people still have symptoms. Now, how to treat a patient with acute MI and coronavirus at the same time, that's a little bit difficult, and it has to be a case-by-case approach. Obviously, because of the because the virus is so highly infectious, the staff, hospital staff treating a patient like that will be exposed for a prolonged period of time, taking care of the patient. So taking a patient like that to intervention to the coronary laboratory poses a trick. Remember also what we talked about, the fact that a person is predisposed to forming more thrombus, more clots, as a part of being ill with coronavirus. So each intervention has to be chosen individually. We have been given, in certain situations, blood thinners instead of taking a person for the intervention and opening the blood vessel if the situation was critical and the person was too unstable to tolerate an invasive procedure. So it plays into fact also that a lot of the times, and this is something we saw in the first wave of pandemic, people were afraid to come in with chest pain because the hospital was full of ill patients with coronavirus, because people were so afraid of getting infected. So a lot of people did not seek care for their cardiac conditions or other conditions, in fact, because they were afraid to get sick. And the other thing we saw a lot of, so the people didn't come in with that, and the system was so overwhelmed with the ill patients, with multi-organ failure, with respiratory failure, that a lot of the times the heart attacks, there was a delay in recognition and treating the heart attacks as a result of the fact that the system is so overwhelmed. And all of this plays into a role. So heart disease mortality actually went up over the year of 2020. And we'll talk about it in a bit. We'll go to the next slide. Okay, the other thing we want to talk about is myocarditis. So myocarditis is inflammation of the heart muscle. The way myocarditis occurs in coronavirus is the same so similar way it occurs with other viruses. The virus causes an inflammatory response. Virus does infiltrate the cells, the myocytes, the cardiac cells, and it causes them to dysfunction. And then there is also the inflammatory response from the immune system that adds on to it, and the cardiac cells become swollen and dysfunctional. It can lead to scar formation from myocarditis and dysfunction of the heart muscle itself. It's severe enough. So myocarditis is treated with anti-inflammatory medications. A lot of the times we do use steroids in myocarditis with coronavirus because of the response rate, because a lot of it is inflammatory response. Again, it's diagnosed by presence of markers of damage to the cardiac muscle, changes in EKG. We'll look at the sonogram of the heart, echocardiogram, to see if there's dysfunction of the heart muscle. Access to cardiac MRIs and biopsies to diagnose myocarditis have been very limited, and it really depends where you are, what health system you're in, how much the health system is overwhelmed with the ill patients. It has been limited, so there is no really good sort of study saying, well, in patients, in the sick patients, this is the percent that had myocarditis. We do see it, and there have been some studies published of myocarditis cases in mild or moderate coronavirus, including athletes. And it is a small percent of the people who are presenting, they actually have markers and actually have MRI evidence of myocarditis, but it is real and we have to talk about it. Sorry, I think the slide is a little bit displaced, sorry for the formatting. So we talked about the acute injury, and an acute injury, I guess, falls more into the type 2 MI, because we do, when we perform biomarkers on ill patients, we notice a lot of them have positive biomarkers for cardiac damage, even in absence of chest pain, just because people are so severely ill and there's such a demand in the system. And then heart failure. Well, heart failure is a sign of other things going on, multi-organ failure. I mean, people who have heart failure to begin with, congestive heart failure and low heart function, they have highest risk of suffering with severe coronavirus illness and dying. There is also this this entity called stress cardiomyopathy. Basically, a very severe, including viral illness, can cause a transient dysfunction of the heart. It's thought to be precipitated by presence of inflammatory biomarkers and stress, epinephrine and other stress hormones in the body, and does affect contractility of the heart muscle. Now, if the heart failure is severe, these are the patients that require support, including special machines that we could put into the heart to replace the heart function, and replace the lung function. Now, it's rare cases of severe coronavirus disease. It doesn't always work, but sometimes we are lucky if we put in a pump such as left ventricular assist device, or a pump such as that circulates the blood through a heart-lung machine, such as ECMO, extracorporeal membrane oxygenation. We can support the body until we either get this person to transplant or to a slow recovery. We can go to the next slide, please. Okay, so we have to talk about the big elephant in the room, and its risk factors. The risk factors have never gone away. What we notice with coronavirus itself is it's the same cardiovascular risk factors we always talk about that make somebody super sick. So there is association with prior presence of cardiovascular disease or presence of the cardiovascular risk factors for people who are a lot sicker when they get coronavirus. And one of them is hypertension. And depending on the case reports, the range is anywhere between 35 and 57% of the patients who are ill enough to be hospitalized. We're talking about moderate to severe and severe illness. As high as 35 to 57% in different studies have presence of hypertension as one of the risk factors. Coronary artery disease patients don't do well with coronavirus illness either. One of the CDC reports as incidence as high as 28% of people who are very ill with coronavirus, they have coronary disease. Why this happens, why is there this specific predisposition? It's not quite clear. It's yet to be studied. We just noticed these patterns. Diabetes itself, it's a risk factor for worse disease with coronavirus too. Up to 19% of people who are severely ill, they do have diabetes. And then the big one is obesity. Obesity is associated independently with much higher mortality with coronavirus itself. Now, presence of any one of these risk factors, diabetes, cardiovascular disease, or hypertension, increases the risk of ending up in intensive care in ICU by 2 to 3-fold. We can go to the next slide, please. And then we have to talk about the death. So overall death rate depends on sort of what information you read. Official, based on Johns Hopkins and CDC, it's about 1.6% in the United States. Russia reports about 2.8%. China, depends on information you read, anywhere between 2.3 and 4.4%. But if you look and break down in the studies that report death by risk factors, the risk factors do increase. So presence of cardiovascular disease, presence of diabetes, presence of hypertension, increase risk of death significantly. So all of a sudden, the presence of cardiovascular disease in one study from China says, well, now the death rate is up to 5% in those patients, and then it's up to 7% in the patients with diabetes. Again, the numbers are sort of fuzzy because there's so many different studies. In some of the meta-analysis, the numbers still end up being high. So one of the studies quotes the rate as high as 10% mortality rate for people who have cardiovascular disease, who end up having moderate to severe COVID. In that particular study, it's 7.3% rate for patients who have diabetes, who end up dying with severe coronavirus, and about 6%. Now, it doesn't imply that hypertension itself causes the death. It's just, it seems that these risk factors for cardiovascular disease are the same risk factors that increase mortality if somebody's ill with coronavirus. So if you're sick to begin with, you're much worse. If you have risk factors to begin with and you end up being sick with coronavirus, these are the patients that have a much higher chance of dying. Next slide, please. So obesity, I wanted to talk about a little bit more. Obesity is concerning because obesity is a part of this metabolic syndrome, and metabolic syndrome is also a syndrome of increased inflammation. Now, you remember coronavirus itself causes increased inflammation. So it seems that patients who are obese, and obesity is defined as body mass index, which is a calculated number of weight over height squared. So BMI of 30 or above increases the risk of pretty severe coronavirus illness. It seems that the patients who are obese, they actually express this ACE2 protein. Remember we talked about it in the beginning? They overexpress it on certain cells. And because of that, makes them more vulnerable to the coronavirus and makes them sicker when they do get sick with coronavirus. There's also, increased injury to the lungs in obese patients on the molecular level, which has been reported, but there is no statistics, how many people. And obesity itself also affects how a person can take a deep breath in, how they breathe. And because of the limited chest expansion, because of the extra weight, limited movement, the person who is obese does not breathe well to begin with. And it just gets worse when they're ill and their lungs can no longer exchange oxygen properly. There's also increased risk of clotting with obesity itself. And if you couple it with increased risk of clotting of coronavirus, these are the people who end up having pulmonary emboli, the clots that travel to the lungs. These are the people who end up having worse issues with stroke and clotting issues in the legs. Now, one of the statistics which I found striking, and I put it here, one of the studies mentioned that there is a much higher risk of hospitalization if a person is obese without accounting for additional risk factors. It's 113% high hospitalization rate if you're obese and you have coronavirus, and 74% higher rates of ICU admissions. And obviously what we talked about before, mortality rate. Next slide, please. So just to summarize, the impact of the coronavirus on the cardiovascular disease. So it's twofold. On one side, it's the damage the virus causes itself to the cells of the heart and the myocarditis. It's also, the way the virus affects, and causes the heart to end up having arrhythmias, having heart dysfunction, leading or increasing risk of the heart attack. It's also the stress of the major infection on the body and increased demands where there's not enough oxygen and the heart has to pump faster. And overall, when you lead to multi-organ failure, somebody who has a weak, heart becomes another organ that fails, and this leads to congestive heart failure. The other side of this effect of the coronavirus on cardiovascular disease is access to care, because the hospitals are full of ill patients. Some people with early signs and symptoms of cardiovascular disease may not even be related to coronavirus illness itself, may choose not to present early enough with their symptoms to a doctor or to the hospital because they're afraid to get sick. The hospital systems itself, depending where you are, is under severe strain at the moment. Some places better than others. Here, I'm in New York. It seems to be sort of a little bit more getting under control, but there are some parts of the country where there are so many ill patients with coronavirus, the system's overwhelmed. So a person coming in with a heart attack to ER may not get care fast enough because the system is so overwhelmed. And also, access to care. There are places in the country where you can no longer transfer patients to, intensive care because intensive care are full of patients with multi-organ failure because of coronavirus. So cardiovascular care is affected by that because people cannot get the proper surgeries, people cannot get the proper treatment because the system is overwhelmed. So I don't know how much time we have. I have I have a little bit of talking points about prevention in general. And I have a few things to talk about potential treatment. So it's up to you if you want to stop here, if you want to talk a little bit more.
Yeah, I think we have about 5 or 8 more minutes before we want to start taking questions. So that would be great. Yeah.
Okay, no problem. So just to mention there are some things in the pipeline that are a little bit more exciting. And some of it just came out recently in the last few months. So we didn't have good treatments for coronavirus itself as an illness, and a lot of it was supportive care. There was a lot of scrambling and trying, based on case reports, what is the medication that can help or save a person. But we do have some medications now that tend to help, but there's some additional ones in the pipelines that may help. So remdesivir is one of the IV medications. But again, these are the medications given to moderate to severe and severely ill patients in the hospital. These are not medications the person can get outside of the hospital. So remdesivir is one of the antiviral drugs that we can give in IV form that can reduce or speed up recovery in somebody who is ill with coronavirus. It does have side effects. It's not a perfect medication. It's not a cure. But it can, in fact, one of the common things we see is kidney injury because of that. But it's something that we do have available now. There's also monoclonal antibody. Everybody heard of Regeneron at this point. It's been heavily advertised in the media. But monoclonal antibodies is something that a person who is ill with coronavirus, but not severely ill, may be able to get by going to an emergency room. Granted, it is available there. And it is a monoclonal antibody that can be given to reduce severity of the disease. Again, it has to be going to emergency room. It has to be available, but it's something that's available to some of the patients, for example, who are not vaccinated and who are becoming ill or high risk. Usually it's people over a certain age with multiple medical conditions who are high risk, but it's something that is available to give. And then dexamethasone, steroids, is something we have been using. In the beginning of pandemic, we were afraid to use steroids. But when it emerged that the inflammation plays such a huge role, there were different inflammatory marker modulators that we tried to test. But what happened we noticed that the steroids, particularly dexamethasone, has been very useful at decreasing the inflammation. It's particularly useful in treatment of the myocarditis related to coronavirus illness, but it's not FDA approved. So keep in mind that the treatments we have were somewhat experimental. There were a couple of treatments that failed along the lines, and it did get a lot of media attention. One of them is hydroxychloroquine, and FDA withdrew in June of 2020 its emergency use authorization for it for this reason. In another very controversial medication, again, we won't delve in too much to it because this is not the focus of the discussion, but ivermectin so far has not been FDA approved and has not proven in the clinical trials to be effective in treatment of it. Now, there are some case reports and things like that, and there's some political things that are emerging about this medication, but it has not been FDA approved, and as physicians, we cannot use it. And there are a couple of medications in pill form that a couple of pharmaceutical companies are working on, and they've been very excited about it. They're not FDA approved yet, not here in the United States, but there are two pills which are antiviral medications that are being developed to reduce risk of hospitalization and death. I mean, this is just for now studies emerging from Pfizer and also another study from Merck for different medications. They have been reducing risk of reducing death, but the studies are somewhat small. We don't have clinical trials, good clinical trials of these medications yet, but it's something in the pipeline, so it gives us hope. And obviously, next slide, please. Most important part. So we have tools now to prevent people from getting infected. We know it's not 100%, but the effectiveness of vaccines is high. The vaccinations are effective. Vaccinated people have, even if they do end up developing disease, do much better in terms of mortality and hospitalizations. And unfortunately, the topic of the vaccination and side effects is a little bit too big for today's discussion. But if you were to do anything a year ago, wouldn't you jump at the chance to get vaccinated? You know, just to put it out there. I know their individual preferences, but it's something that's so important. We have tools in our toolbox now. It's better than it was in the beginning of pandemic. I think we'll stop here, and yeah, I'll take a few questions if you can.
Fabulous. That was wonderful. Thank you very much. And we did talk last week a lot about the vaccine, so that was great. But this information was fabulous. And I'm going to turn it over to Mandy to go ahead and ask some questions.
Sure. So we've got a couple of questions revolving around heart failure. So the first one is, if a person has heart failure, how much risk do they have of being exposed to COVID? I know that you can't really say that for sure, but can you comment on that, heart failure and COVID?
So we know that people with heart failure usually have other underlying risk factors. It's not heart failure, it just happens spontaneously. You know, these are the people who also have hypertension. These are the people that often had heart attacks. These are rarely it's because of infiltrative heart disease and so on. So we know that these people are at much higher risk of having severe illness. Percent-wise, I wouldn't quote you. There is no great studies on it. We know that people who have heart failure, in severely ill people, up to 50% the ones with heart failure, they end up dying. But that's just one study that I could think of off the top of my head. So having heart failure, yes, it does increase your risk significantly of having worse illness. Because remember that the demand on the heart during the illness is to pump harder. If you have a heart that's not pumping very well to begin with, it's already failing. It will not be able to catch up to the demand. If your lungs, and part of heart failure is also accumulating fluid in the lungs very often. So if you have something that you have fluid in your lungs to begin with, and then you have acute lung injury because of the coronavirus, you will be a lot worse off fighting the disease because you don't have good oxygen exchange. Another part of the heart failure is cardiac transplant patients. it seems because of the immunocompromised status, we have had many reports of death in the cardiac transplant patients. These are the patients who had heart failure before and were on immunosuppressive medications after the transplant. So heart failure itself definitely increases the risk. It's one of the risk factors. We didn't talk about it because we don't have really good studies what % of the heart failure patients end up hospitalized. But we know that heart failure is present in a significant amount, up to 50% of patients with severe illness. Next question, please.
Yeah, about heart failure also, can the vaccine protect people with heart failure who get COVID?
Well, vaccine is, based on information we have, depends on the vaccine you took, can be in the high 90s or 90% effective, right? So if you're at risk and you're vaccinated, you have much better chances of not being severely ill. Is the vaccine 100% protective? Well, as I said, the numbers are good. There's a good chance that if you're vaccinated, you will not develop major illness because your immune system will be able to recognize the virus better. So same thing is with other risk factors. And anyone with hypertension, if they're vaccinated, their chances are better. Anyone with diabetes, anyone with coronary artery disease, if you're vaccinated, your chances are better.
What do you tell your patients if they've been vaccinated and they've had the booster and they are cardiac compromised? What do you tell them when they ask if they can go out to restaurants or the movies in terms of worrying about the risk?
I won't tell you, I'll show you.
Mask up.
Mask up, caution advised. Unfortunately, the pandemic is not over. You have to be cautious and protect yourself. Unfortunately, we don't have a very good way, except sort of talking about risk factors and who's immunocompromised and who is not, about guaranteeing that everything will be 100% protected. So the social distancing, wearing your mask in public, avoiding areas of poor air circulation is still very, very important. I tell my patients, don't let your guard down. Don't let your guard down just yet. You're doing everything to protect yourself, and that's good. You're addressing your cardiac risk factors. That's good. You're taking your medicines. Fantastic. You're vaccinated. And I go, yes. It was very exciting to see our patients vaccinated. But it's not 100%. So if you think you're immunocompromised, then definitely avoid places where you will come in contact with other people who may not be vaccinated or who can have coronavirus but be asymptomatic. So caution advised. And obviously booster. For those who are immunocompromised, we do have boosters, and it's probably going to play a major role in the future.
I know you're not a pediatric cardiologist, but we do have a question from a CHD dad who is wondering about his 5-year-old who has multiple heart defects and whether or not to get the Pfizer pediatric vaccine that was just approved. Do you know if heart patients were part of any of the Pfizer trials for children?
I don't think that they published the data specifically for even young patients who have had multiple risk factors. The trials were done in generally healthy population. So I don't think you have specific data for somebody who has cardiac defects. We know that vaccine was tested and a Pfizer vaccine was approved for 5 years and older, but we don't have the data for someone who has multiple risk factors. It's something that you take this question to your pediatric cardiologist and you have a good discussion about it, because obviously there are potential benefits, a lot of potential benefits. This is to me personally, it sounds like a child who is at higher risk of having complications should the child become ill with coronavirus. So it's a good question to bring to a pediatric cardiologist in terms of the studies. I know this is just the beginning. We will have more information as people get vaccinated, and as children get more vaccinated, there will be more information how it works in real life. What we know about the vaccines is that we know that kids respond even better than adults. Kids do generate antibodies for these vaccines, and they are protective to kids just as much as they are to adults. But specifically for each medical condition, like children with medical conditions, and generally I would think that kids with medical conditions or immunocompromised, these are the ones you want to protect the most. But I think individually, depending on the medical condition, you have to take it to a pediatrician or your pediatric cardiologist.
We've got one more question, and that's about valve replacements and COVID, and are there any implication for people who have valve replacements?
So, with the valve replacement, there's no specific data how, if you have a replaced valve, how well do you do if you're ill with coronavirus itself? There was nothing really in literature, even from China, published, because the studies that have been published are sort of small, saying, well, this percent of people have diabetes, this percent of people have that. So how do people with heart valve disease fare? I know that with recent heart valve surgeries, we have seen a high number of people being hospitalized with coronavirus. And I'm not sure it's because of the recent surgery itself being the risk factor, and that their body is just not as strong. But there is no specific data to say how heart valve disease patients do. If you think of it association with other cardiovascular risk factors, then it would make sense that they're at higher risk. But there's no information data saying, oh, you're doing better than somebody who has coronary artery disease or not.
That's it for the questions. Someone did ask where they could get the slides after, and they will be on our website along with the recording of this. Your information was excellent.
Thank you so much for your time. I appreciate it.
Yeah, thank you, Dr. Nelipovich. Thank you so much. I so appreciate it. And
thank you so much.
For the next session we have coming up, our last session of the series is going to be COVID and a cardiovascular disease moderated patient panel, where we will be talking to patients from all different perspectives who have cardiovascular disease and have also experienced COVID. And we are going to be able to answer and ask a lot of questions. This will be moderated by Dr. Jason Robin, and it is going to be on November 16th at 8 p.m. So tune in next week, and we look forward to seeing you. Thank you so much for joining us today, and we appreciate your time.
Thank you for the opportunity.
Have a great day.
Thank you. Take care.